Good morning, everyone. Great to see everybody. Thanks so much. I've been following you all on chat. Nice to see you from Kentucky, Troy, Michigan, Seattle, and all the rest. It's just fantastic and really exciting to see international folks. Yes, our friends in North and Canada, you're actually international folks, but we've got folks dialing in everywhere from the UK to Africa. So thanks so much. It's certainly an important topic that's getting a lot of global attention. So we'll kick it right off. I'm Dan Burke. Nice to see everybody. For those of you who are on the first Crest Oral-B Oral Systemic Health webinar series, 6 weeks ago or so, that one was with Dr. Dillenberg, Dr. Aaron Hartnett from NYU, and Judy Haber also from NYU, and Ann Rice. Thanks for coming back again. Really appreciate it. This is the second installment of that. And so I will kick it off with a few administrative things. First, again, I'm Dan Burke. Nice to see y'all. I wear a couple of hats. One is I'm here as Vice President of the Pacific Dental Services Foundation. The foundation is dedicated to a number of causes, one of which is the communication and education about oral systemic link, body connection. We're very active on the public policy side as we are promoting with a coalition of about 133 groups, the expansion of Medicare so that our nation's elderly can have dental benefit, especially those who have periodontal disease, as well as other systemic conditions. So that coalition, which we're proud to be a part of, contains everyone from the AARP to the American Diabetes Association to California Dental Association, among many, many others. So proud to be associated with the PDS Foundation. Those of you who know us in Arizona, we have a special needs clinic there, and it's obviously to serve patients, but it's also to train dentists and other clinicians who want to work and serve that terribly needy population. It's a population who tends to have a hard time finding dental care that are trained and suited for their needs. So very proud of that. And my other hat is I'm a Chief Enterprise Strategy Officer of Pacific Dental Services. So that's me. So I'm going to jump in first with some administrative matters. First, chat room, use it. I will watch it. As our presenters, I hope don't. They can be distracting, but I'll certainly watch it. And I will be writing down questions. So during Q&A, obviously you can type in questions then too. But if you type one in during the presentation, I will try to see it. Nothing wrong with typing it in twice, by the way, if you think it slipped by. But I will try to take notes of those and make sure we get to those during Q&A. Most common comment I have found has to do with people's bandwidth. I would love to say that I can help if you're having connectivity issues, but I can't. So the general advice is there is a reconnect button at the top. So if you have any trouble during this presentation, connect there. If that doesn't work, you can refresh your browser. If you're using some browsers, some work better than others. Google Chrome works the best, just FYI, and Safari works pretty well. Internet Explorer does not work so well. And then the last thing, if it really doesn't work for you, I suggest you switch to your phone. This is mobile configured. So there you go for that. Otherwise, we'll go about an hour, and there will be Q&A after that. And there is a CE code for all of you who are on and will benefit from CE. So the CE, I'm answering right now, Miriam, the CE code will pop up during Q&A. So write it down and you'll enter it in to make sure you do get your CE. I think that's it for administrative stuff. So let me do a quick thank you. First, Crest Oral-B. Dave Scholl, Andrew Giangreco, and the team really appreciate their support of the oral systemic health education initiatives. It's just so important. I know the clinicians who are working in the space have known this for years, but the more that patients can come to understand that the mouth is connected to the body, which generally doesn't surprise people, but that the maladies of the mouth, the bacteria in the saliva and in blood does impact the rest of the body in a very real way. And that's what this is all about today. We'll be focusing on COVID and the interaction there, but we'll certainly expand out from there as well. So thank you, Crest Oral B. And Jed Ivey. Some of you who have done a number of these know who Jed is. Jed's behind the scenes, the man in the basement controlling all this. So thank you, Jed. And Sarah Thiel from CE Zoom for putting this together, and Laura Dildy from NDA Media also for producing this. Really appreciate all of your help. So we're going to jump in. I'm going to introduce our panelists, and they are phenomenal, just world class. So I'm really pleased to have you here. So hopefully everyone can hear us. I know I get a few chats here that from a couple of folks, but hopefully they will figure all that out. So let me jump in. I'll introduce our panelists. So first, I'll introduce Dr. Amy Doneen. Dr. Doneen is an international leader in the field of arteriology, and she's the co-founder and a principal instructor in the Bale-Doneen method. She is Doneen of Bale-Doneen. That method, by the way, is practiced by more than 1,000 healthcare providers around the world. I myself have gone through the Bale-Doneen training a number of years ago, and it's a remarkable thing to do. You're sitting amongst medical doctors, amongst dentists, nurses, nurse practitioners, hygienists, all learning together how they can work together for the benefit of patients. It's remarkable. Dr. Doneen is also the owner and medical director of the Heart Attack and Stroke Prevention Center in Spokane, Washington. That's a highly sought after private clinical practice that serves patients who literally come from around the world. She holds professorships at the Washington State University School of Medicine, the University of Kentucky College of Dentistry, and Texas Tech University Health Science Center. Dr. Doneen has published her research in many leading medical journals, and she's the co-author of Beat the Heart Attack Gene, the revolutionary plan to prevent heart disease, stroke, and diabetes, a book I have right next to me. And in 2017, Bale-Doneen published a landmark paper that many of you are aware of, demonstrating for the first time an actual causal relationship between high-risk periodontal pathogens and cardiovascular disease. This article has been cited and referenced and downloaded over 25,000 times. Most recently, her paper on a migration from the binary to ternary approach to cardiovascular risk identification is of the top viewed papers in the International Journal Frontiers. Most recently, she co-authored The Enhancement of Innate Immunity to COVID-19 with Natural Measures, which is what she's excited to share with you today. So very, very timely. We're very appreciative to have Dr. Doneen with us. Hi, Dr. Doneen.
Hi, thank you.
Good morning. And I'll introduce Dr. Victoria Sampson, and we will kick off. So Dr. Victoria Sampson does not get the prize for longest dial-in. Sorry, Dr. Sampson. We've got folks from Africa and really all over, which is remarkable. So I thought you'd win the prize, but it goes somewhere else. Good morning. I'm going to embarrass you, Dr. Sampson. I'm going to read your bio, which is just phenomenal. So Dr. Doneen, phenomenal. Dr. Sampson is, yes, dialing in from London. She's finished her full work day, so thank you so much. Just saw her last patient. She's a general dentist practicing in central London. She obtained her bachelor in dental surgery from Barts and the London School of Medicine and Dentistry, where she was also chosen to represent the UK in a 4-month training program at the renowned Karolinska Institute in Sweden. Upon graduating, she ranked in the top 100 newly qualified dentists in the country. Top 100 is pretty good. I happen to know she was also named UK Dentist of the Year. So it's not in your bio, but I know that, so I'm going to say it. She's been at the forefront of change in dentistry by undertaking research projects in multiple fields of dentistry and taking a special interest in the relationship between the mouth and the body. She's published numerous papers in the UK and internationally. She's won prizes for the British Society of Dental Maxillofacial Radiology, the Association of British Academic Oral and Maxillofacial Surgeons, and most recently, yes, she did win the Best Young Dentist Award by the British Endodontic Society. And part of the reason she's here with us today is all of that, but she also published an article that many of you are aware of in the British Dental Journal back in June of 2020 regarding the potential connection between oral health and COVID-19. It is now the most cited and viewed article in the British Dental Journal, and it is in the top 1% of all research tracked ever by Altimetric. So it has quite literally gone global. Based on her work with COVID-19 and oral health, she has been involved in research with the UCL Eastman Institute on the oral microbiome and COVID-19, as well as passionately helping to reduce complications from COVID-19 with oral care donations to the elderly and the vulnerable. So I think you will all agree that these panelists are just world class, and I'm honored to be able to facilitate your conversation today. So, and with that, we'll jump right in. So, if it's all right with you, Dr. Samson, just love to know what's going on in London. Obviously, you're tracking our news, we're tracking your news, but what's sort of the state of play with COVID there?
Well, COVID's been very interesting. At the moment, we're in our second lockdown. So everything's pretty much shut except for the, supermarkets and dental practices and medical practices, etc. So it's been a bit interesting. It's been a bit of a lull. Everyone's quite sad and down in the UK, but I guess it's for the greater good. I mean, I've been following the US news a lot more. I think there's a lot more exciting things going on across the pond than over here at the moment. But in terms of COVID, I mean, the good thing is that this time around with the lockdown, we're still working. The first lockdown, we were shut down for 4 months. And we're still paying for that, for the impact of that. And we're going to be covering that a lot today about how important oral hygiene is and why, dentistry is not, it is a very important part of medicine. And if you want to be healthy, you need to have a healthy body as well as a healthy mouth.
Yeah, no, I appreciate that. And I hope during this time that we get to that as well. Because in the US, when we had our shutdown, what we found initially was with dentistry, and we understand it wasn't thought of initially. So when some of these larger decrees came down about shutting down, they didn't exclude dentistry from the shutdown. And we ended up dealing with a lot of issues from that. Luckily, we rallied pretty quick in the US, and it became very apparent that dentistry was, oral healthcare is necessary, and to close down part of our valuable healthcare system, certainly had deleterious effect. So we think we've learned from that, but we do want to remind people that dental is safe. Dentists and hygienists, clinicians have been dealing with infectious diseases their entire career. Oh, wow. Not to make light of this, but it is yet again just human beings walking into their offices. So, well,
actually, I mean, like the new research that's come out has shown that only 2% of dental professionals have actually acquired COVID-19 or have antibodies against it, compared to about 6% of the general population. So it could be that the dental profession is fantastic with disinfection protocols. We've always, like you said, this isn't the first virus we've ever had. We've had, the era of HIV, hepatitis, all of these things, and without scaring anyone at the moment, we've been able to handle all of those. You don't have a huge spike in numbers of dentists or patients who have any of those viruses. And that's because since the beginning, we've always had fantastic disinfection protocol. And there are some people who are arguing as well that dental professionals might potentially actually have some type of immunity against coronavirus. And I'll explain why afterwards when I describe coronavirus a little bit more.
That's great. All right. So actually, if you don't mind, Dr. Samson, let me just pick up on that. Why don't, if you could set the table for us? I mean, I think we have a general understanding out there in the world now of COVID-19, especially folks who would register for this. But let's set the table for our discussion, if you could.
Yeah. So, what is it? What is COVID-19? So on December the 31st in 2019, the World Health Organization basically declared that there was a cluster of about 27 pneumonia cases with no known cause. And it originated in a wholesale market in Wuhan City, China. Then a couple of weeks later, they realized that it was actually caused by a virus. And this virus has a couple of brothers and sisters. So in general, there's 6 coronaviruses, and now SARS-CoV-2 or COVID-19 has become the 7th kind of addition to the family. So 4 out of 6 of those coronaviruses cause the common cold. No one really worries about them too much. We constantly have them, and especially children. They have a lot of these kind of illnesses which are caused by the first 4 coronaviruses. Then the 5th coronavirus is MERS, which is Middle Eastern Respiratory Syndrome. And then the 6th one is SARS. And then now the 7th one has now become SARS-CoV-2. So basically MERS and SARS, which were, I think it was in 2008. SARS and MERS basically they're very fatal and they can cause a lot of problems. And they've actually now been declared extinct and we don't have any more SARS or MERS around. But SARS-CoV-2 is now kind of the sister of SARS, I would say, because it's 80% similar to SARS. And that's in terms of the genetic data, the DNA, the treatment modalities, everything. It's pretty much 80% similar. So at the beginning of this whole pandemic, no one really understood what COVID-19 was, where it originated from. And a lot of people were actually relying on the research on SARS to then be able to understand a little bit more about SARS-CoV-2 or COVID-19. And I'll constantly kind of interchange between the two because COVID-19 is the disease that you get and SARS-CoV-2 is the virus. But unfortunately, people kind of mix them all around. So just for anyone who's listening, SARS-CoV-2 is COVID-19. It's just the disease that it causes, basically. So in terms of what COVID-19 can do, the general signs that most people now know are a fever, fatigue, having sneezing, runny nose, sore throat, dry cough, shortness of breath. And then as the months went by, there were a few more kind of signs that started originating. And that was diarrhea. That was a really big sign. Some people were also getting rashes on their chest, their feet, and their arms. And then also the idea of a decreased function, not only of their kidneys, but also just their general immune system was kind of being affected from all angles, and it usually started another kind of infection or another kind of problem. So a lot of people, they didn't necessarily die of COVID-19. They died of the complications that originated from COVID-19, and that's quite important to understand that people were dying from heart failure or from respiratory acute distress syndrome, all of those types of things, as opposed to the virus itself. Moving on to the oral signs. So this, because we've got a lot of dental professionals here, I thought this was quite interesting. So these are some of the oral signs that you might actually be able to pick up in the dental practice. Some patients or some dentists are starting to see that patients are getting petechiae on their palate. So these are very tiny, small blood vessels on the roof of the mouth, which burst. And I think Dr. Doneen is going to go into a little bit more detail on inflammation and why this might happen. But even though it's a whole body thing, it even can appear in the mouth too. And as a dentist or a hygienist, you might be able to notice that. And then if you go on the left-hand side, you'll see that there's a lot of people who are getting fungal superinfections, bacterial superinfections like thrush, etc. And they were getting ulceration as well. I had COVID-19 myself in March, and I had ulceration, and I also had a huge rash all along my chest. So this isn't, an uncommon thing. This is something that does happen to the normal person, you and I,
Yeah, in fact, I'll chime in. This may be unusual for a panel. It was not planned, but I should say a panelist and a moderator, 2 out of 3 of us have had COVID. So I have also had a COVID infection that thankfully I am through as well. But hopefully you'll hear we speak with some degree of empathy. I see the comments, and some have spouses or loved ones dealing with it currently. And so just know that you have, and certainly Dr. Doneen does not need to have it to feel empathy, but just know that this panel certainly understands. So appreciate the oral signs on that. What are some of the risk factors that people should be aware of?
So the main risk factors, the first one that came out was age. So the idea of anyone who was over the age of 70 years old experiencing much worse complications than those who are under. And then the next thing was gender. So bizarrely, men were more likely to develop complications than women were. And there's a lot of kind of argument that potentially it's because, maybe they were more exposed or, all of this. But at the end of the day, it might be more of a genetic predisposition as well. Then race. People who are from Black, Asian, or Middle East Middle Eastern minorities are more likely to, also 4 times more likely to get COVID-19. And then I think the most important thing that came out in around February was the underlying comorbidities in 48% of cases of COVID-19. So from the underlying comorbidities, the most likely one was hypertension. 30% of patients who had COVID-19 had hypertension of some sort, which is high blood pressure. Then 19% had diabetes, 8% had heart disease. And then a month later in March, France then realized that actually 47.6% of the patients who were hospitalized with COVID-19 were obese, and they had a high BMI. And so, I mean, every month we're starting to see more and more risk factors which are added onto it. And for me, what the reason that I started my research and I started to delve into this was because all of these comorbidities, they add up to 48% of cases. So what do the 52% of the population, the other 52% who get COVID-19, why do they get it? And why is it that some patients have absolutely no symptoms, or they might, just have loss of smell or loss of taste, and then other patients have, awful chest infections and coughs, and they have to go to ICU and they put on ventilators. It's not just these underlying comorbidities, and I think there's a lot more that we don't know about COVID-19.
Yeah, and thank you for that. And Dr. Doneen, I've heard you speak on the topic. So not only are some folks at higher risk of contracting COVID, it certainly seems the data says, but they're also experiencing much more serious symptoms up to and including death. What is your research finding?
Yeah, so one, I just want to say thanks, Dr. Samson, for that, and it's a real thrill to be on this meeting with you. So thanks for Dan inviting both of us together. It's wonderful. And one of the exciting things that I think this call does and this seminar does is it really brings in once again the correlation between oral health and cardiovascular health. My focus 100% here at the clinic, and also the work of Doneen that we've been doing for 20 years, is to understand who is the most vulnerable for vascular disease and what can we do about it? Because there's no question that we can identify, treat, stabilize, and regress atherosclerosis affecting the large, such as heart attacks and strokes, and the microvascular system as well. So in May, in New England Journal of Medicine, they really took a worldwide synopsis evaluation asking, who's being hospitalized for this? Who are the most severe and at-risk patients who are hospitalized from this virus? And what got our attention is our people. These are the people that I have the honor to work with every day. And they're people that also have the very similar risk factors, and I would argue the same treatment profiles that we see for the prevention of vascular inflammation. So as Victoria said, those over 65, those with coronary heart disease or arterial disease, congestive heart failure, cardiac arrhythmia, COPD, and then also smokers. And I will cover a bit later in our conversation, Dan and Victoria, the idea that if indeed these are the highest risk patients that are being hospitalized for this, based on their entry criteria into the hospital of even their medication profile, can we blunt somehow that aggressive response to this virus and mitigate the mortality associated with it? So I'll go into that as well. So I appreciate that we're all talking about the same disease state, and we all have the ability to come at it through different lenses of expertise. So it's terrific.
Yeah, no, I appreciate it, Dr. Doneen. And that right there, somebody asked me, so why is on the Crest Oral B, Oral Systemic Health series platform, why are you talking about COVID? And it's exactly that. It's everything that we're seeing and monitoring. It says that the connection is the same. It may sound so obvious to some. I think if you're not burdened by a professional degree in the area, it's just common sense, right? You don't have to think about it, that these things are connected. So are you seeing a connectivity as well as treatments? Like if it's a similar group of folks who are being negatively impacted, vascular issues and now COVID issues, are you seeing where there could be crossover in treatment or some of those therapies might work?
Yeah, absolutely. And the second part of this study that they looked at, there were several papers within this group in New England Journal, and they looked at, okay, if these are the people that are actually being hospitalized, what's the likelihood that they're going to survive their hospitalization or not based on their meds upon entry? Because hypothetically, if you have a patient who's well treated for vascular disease, they're going to be on treatments that mitigate their vascular inflammation or mitigate the integrity of a vascular prothrombotic response anyway. So common treatments in my world include things like statin therapy, ACE inhibitors, antiplatelets, vitamin D optimization, and there's several more. But the idea of my patients who are at absolutely high risk, more than ever, do we need the ability to make sure that they're controlling every inflammatory source that they can. And to Victoria's point earlier, when dentistry was closed down in the US for a short of time and apparently in the UK as well, I was very concerned about that, because if we take the overlay of these catastrophic sort of profiles, heart disease, vascular disease, etc., the thing we want to do is make sure, I was very adamant that as soon as they could get into their dental health professional, that they get in, because we want to make sure that if the source of inflammation is coming from the mouth under a backdrop that already supports vulnerability, then absolutely patients need to get into their dentist, and they should not be afraid of it, because there's no safer place probably than a dental office who's had way more education and training and PPE than any other practice as a field. And perhaps I'm a bit biased, but I believe that to be true.
Yeah, no, I appreciate it. I know for me personally, and I've spoke to others, when I first contracted COVID and it was not presenting itself as dire in a dire manner as it has for many others, and I've certainly felt fortunate about that. I was asked well, I guess my MD knew I'm on a statin, and he knew I was already taking vitamin D and some things. So I think I tend to think that that's not a coincidence. And but how are, if you don't mind, I'm going to actually, I know your next slide. Are there other vascular treatments that the folks would want to be aware of?
Sure. Yeah, and I'll cover those in a bit, but under the backdrop of that, when we look at why these people might be more vulnerable for the devastating effects of COVID and viral activity, there's two areas in my world that I want to focus on. One is the profound inflammatory response to COVID. Some people, perhaps the two of you that said that you did have COVID with different symptoms, but fortunately, thank goodness, are okay. Some people have this aggressive response that creates, and I know Victoria is going to talk about this too, a cytokine storm that's going to affect all of the microvascular vessels, including the lungs, the heart, the kidneys, all the way down to the toes. And so this profound inflammatory response, one of the concerns I have is that it also affects the microvascular system, leading to things that are catastrophic with inflammation in the lungs, i.e. pneumonia and breathing problems, pericarditis of the heart, end-stage kidney disease. It is a systemic impact from the virus that is so deadly. And so when we look at these patients that produce this pro-inflammatory cytokine response from the interleukin family, regulation of neutrophils, and basically an attack to the virus, results in a very fragile arterial system that leads to catastrophic illness in some people.
Right. I appreciate it. And I know those comments are spot on. I'm watching the comments, and they were quite literally asking about interleukin 6.
Oh,
so I appreciate that. So how about, so what is, Dr. Samson, if you don't mind me kicking back to you, we hear about bacterial superinfections. So what's going on?
So this is where I really started to do my research on, because obviously we know it's viral infection. But with a lot of viruses, the main problem occurs when a bacterial superinfection happens. And we saw the same thing with the 19 influenza outbreak. And again, with the influenza in 2010, we saw exactly the same thing. And so the problem is that with a virus like influenza, let's take that as an example, it's a deathly virus. But again, people were not dying from the virus itself. They were dying from the subsequent bacterial infection. And the problem is that with outbreaks such as influenza, such as, the first SARS or SARS-CoV-2, we're not doing enough research to actually look at the bacterial superinfections that happen from a viral infection. And so because there's not that much research, it's not a known thing. People don't think, I have a virus, I'm infected. I need to make sure that I don't get a bacterial superinfection now. It's not, maybe for a medical or a dental professional, we can understand, but generally people don't understand why, a virus could potentially be connected to a bacteria. And so there's a lot of papers which basically were looking at the connection between a bacterial superinfection and COVID-19. And this one was really good. It's by Cox et al. In 2020, obviously. And basically what it was showing was that over 50% of severe COVID-19 patients had a secondary bacterial infection when they died. And so, that's huge. And then on top of that, 71% of patients who were admitted into the hospital were requiring antibiotics. And again, just to remember that antibiotics for a bacterial infection, and these patients were admitted for a viral infection. So we're seeing this huge connection between the viral infection and potentially a bacterial superinfection. And then if you look at the last point, it's 74.5% of patients admitted to ICU required antibiotics. And just to because COVID-19 is such a new virus to us and we don't quite grasp it, I like to always compare it to other viruses that we do know. And one is HIV. And HIV is a virus which can cause a lot of problems. But again, the biggest killer of HIV is not HIV itself, but bacterial superinfections. And so this is basically the basis of a lot of the work that I've been doing to see where does that bacteria come from? Why is it that one patient will get a bacterial superinfection and the other one will not? And if we move to the next slide, that's it. So to further confirm this idea of this bacterial superinfection, a lot of researchers started looking at what was the difference between a patient who had very severe COVID-19 and a patient who had moderate COVID-19. And what they were finding was actually the levels of lymphocytes and neutrophils were different. And this kind of links in again with what Dr. Doneen was saying about neutrophils. And so what they were finding was that with patients who had very severe COVID-19, they had a very high neutrophil count and a very low lymphocyte count. And with patients who had a moderate COVID-19 reaction, they had the opposite. So that means that they had really low neutrophil count and they had a very high lymphocyte count. So what does that mean? Lymphocytes are the virus killer, I would call it, just to be completely simple. And neutrophils are more bacteria killers. And probably Dr. Doneen is going to correct me for that. But just to make things very, very simple, your lymphocyte levels will be elevated when you're trying to fight a virus. And so what's happening is that these moderate COVID-19 patients who have high levels of lymphocytes and low levels of neutrophils, that means their body is killing a virus of some sort. Then something happens and they go from being a moderate patient to a severe patient. And all of a sudden, their lymphocyte to neutrophil level switches around. And instead of having high levels of lymphocytes, they've all of a sudden got really low levels. And so some people are arguing that maybe the lymphocytes are just exhausted, that they're too tired of fighting COVID-19. They say, all right, I'm done, I'm finished. And that's when you start getting the complications. Other people are saying that actually the lymphocytes are fighting. But what happens is that the bacteria starts to grow and reproduce in your body. And all of a sudden, the body is trying to fight two different attacks. So it's like a two-pronged attack. You've got a virus from one side, bacteria from the other side, and the body just doesn't know what to do. So it's fighting a lymphocyte at one, it's throwing all its lymphocytes at the virus and it's throwing all its neutrophils at the bacteria. and the body just goes into an overdrive. And that's when you start getting these really severe complications. And then if you're going to look at the treatment modalities, if you look at this slide here, this treatment modality had a lot of people hated this idea of using an antibiotic to treat COVID-19. And so this was basically by Gautre in about March. And he found that if you put patients on a combination of hydroxychloroquine, which is an antiviral, and azithromycin, which is an antibiotic, 100% of patients were cured virologically after 6 days. And then if you were just to put the patient on hydroxychloroquine alone, then they were cured, again, only 57.1% of them were cured after 6 days. And for the patients who didn't have any hydroxychloroquine or azithromycin, only 12.5% of them were cured after 6 days. And so this shows that clearly the addition of an antibiotic was able to change the prognosis of that patient from 57.1% to 100%. And this paper had a little bit of backfire because it was quite a small case study. And I don't know, some people who were here might be like, ooh, this isn't a good paper to be talking about. But this was further confirmed in about June. And they basically did a huge randomized control trial with around 2,000 patients. And they found exactly the same thing, in that 98% of patients were virologically cured with a combination of hydroxychloroquine and azithromycin. And so this, to me, kind of further confirms this idea that bacteria is playing a huge, huge role in developing a COVID-19 infection from being moderate to severe.
So, question actually for you both. Sometimes, for me, the non-clinician, it's almost a bit of good news, if that sounds strange, the way it's triggering other responses. And obviously seeing your dentist, seeing your physician is the right thing to do. But there are certain things that can be done at home, right? Certain things, one can go down to CVS, right? And you can buy certain rinses and things. I'd love to just touch on that for a few minutes. What are some of the things that, because obviously the folks, there's a lot of licensed clinicians on here getting their CE, but they're also humans as well with families, and how can they perhaps take care of themselves? Are there some things, and I have a list. I mean, I know I talked to everybody I could when I heard that I may be, that I had come in close contact with someone with COVID. I first tested negative, but I certainly turned myself on even more than I was as far as information goes. And I got a lot of information. How about, are there any things that jumped to your mind, Dr. Doneen or Dr. Samson, about things that people could be doing now if they haven't contracted it, or once they do contract it, more like call it a home remedy, or available just, down the road at CVS?
Do you want me to take that, or?
Sure.
I mean, Dr. Doneen, you have to tell them about your saline rinse.
I will.
Phenomenal. I've been telling every single patient, I'm like, get some salt, get some water, mix it, it's done.
Yeah.
Thank you.
I'll share my story as well, Dr. Doneen. You were a huge help for me.
Well, maybe we can put it ahead to slide 17 if that's okay, because then people can get more visual. Should I? Oh, there we go. You can just keep going.
I will do it. Just making sure I go to the right one.
Yeah, go to the one where it talks about enhancement of the innate immunity system.
Will do.
But thank you, Dr. Samson and Dan, for recognizing that. What would this one here, Dan, thank you.
Yep.
What we are excited about is Dr. Ramalingam and colleagues in Scotland, actually, a group of virologists, before COVID, they were actually looking at the corona as a whole. And we have to appreciate that our innate immunity system is the first line protection against any pathogen. When the challenge with COVID or any coronavirus, it is an encapsulated virus, and so it gets intracellularly, and it's airborne, right? So it gets to the epithelial cells that line the throat and the nose and the nasal passages, and that virus gets intracellularly and then starts to raise havoc. So when this foreign microbe invades a cell, cytoplasmic receptors recognize the intrusion and immediately activate the immune response response to prevent the replication of the pathogen. That happens innately for a lot of people. But what we also need to appreciate is that we can do something to help that. So how does this innate immune response, how can we encourage that? So what the trial was called the Elvis trial, and what Ramalingam and his colleagues found out is that they could affect the development of hypochlorous acid intracellularly by manipulating different doses of saline, as simple as that sounds. So what they found is that exposing the cells to chloride from a concentrated saline solution improved the capability for inhibition by boosting this quality of something called hypochlorous acid. Hypochlorous acid is going to stop the replication of the virus, stop the proliferation of the virus, both corona and COVID as well. So it demonstrated that we can enhance or activate that immune response directly with the epithelial cells intracellularly, and greater exposure to chloride, which can safely be delivered just by, quite frankly, salt water. The World Health Organization and also several others are calling saline a myth. And to be honest, they're right, because what they're looking at is a 0.9% solution. In order to get the ability to create hypochlorous acid intracellularly and suppress the viral replication of this virus, you need a 3% solution. And to make things really simple, that's 2 cups rather of distilled water and 1 tablespoon of good old-fashioned table salt. And what the research has demonstrated is simply gargle with the salt water. It interacts with the epithelial cells in the throat, and spray, nasal spray, basically the 3% saline, and it interacts with the epithelial cells that line the nasal passages. The difference between this saline research and topical treatments that can kill, whether it be iodine or what have you, it can kill the virus topically, but the difference here is that it gets intracellularly and stops the replication, and even showed that it could diminish spreading within households. And I think that's what we want to get out there today, and that is, it's one more tool in our toolbox: social distancing, mass hygiene, and then really regularly bathe those epithelial cells with this 3% to stop the replication of the virus intracellularly if you happen to inhale it in the air.
Right. And on a personal note, I'd like to just actually honestly thank you, Dr. Doneen and Dr. Bale. You were speaking about that many, many months ago, so it was on my radar screen. And I hope, does a Netipot work? I'm just curious. You know that. Yeah, I hope so, because trust me, I was doing that. Yeah,
the biggest thing is the concentration and the frequency. So that's the biggest issue. So you just want to get that saline up into the nasal passages, which isn't very comfortable, but it's safe and easy.
Yeah, it does get easier for anyone who the first time thinks, oh my gosh, but you might not want to have anyone watch you do it. My family wasn't thrilled. Anyway, but if you don't mind, let me stay on this a little bit, just kind of the home remedy type stuff. If you don't mind, I'll tick a few things off, and to the extent you've heard of them or have an opinion, that would be great. When I first came in contact with it, I reached out. I get to know a lot of people in dental in the U.S., which is great. Certainly my own dentist reached out to him, and also Dr. Mary Lee Conicella is someone who's well known to a number of folks listening in. She's the chief dental officer at Aetna and has been a big proponent of oral systemic health for years. She actually sent me a whole bunch of stuff. She said, obviously she knew I was working with my doctor already, but she literally was like, walk on down to CVS. There's a peroxide rinse, and I've seen a study that talked about peroxide rinses for recommending that perhaps dentists have their patients do a rinse before they go in for any treatment. Have you come across anything on that, on just a simple peroxide rinse, or the effectiveness seemed to be much more on the salt saline?
Well, the difference really is the intracellular activity that can be created with the chloride producing hypochlorous acid intracellularly. That's the big difference we're seeing with other topical or homeopathic remedies. And I'll let Victoria answer that from a dental standpoint. It's not my expertise, but the reason we got so fired up about Dr. Remelinguns and his research was that it does stop the replication of the virus within the cell itself.
Okay. Great. As opposed to just killing what might be there, it actually
as opposed to just
the response
on purpose and just trying to get rid, but actually stopping the replication and the shedding of the virus intracellularly is really the ticket here.
Great. Have you had?
Well, from a dental perspective, I mean, I would 100% agree. I mean, I think the idea of using saline irrigation it's so simple but mind blowing. When I read the paper, I was just like, wow, like it makes so much sense, and I think it's a really great thing. And I think the problem with a lot of other mouthwashes out there, not all of them, but the problem with telling the public about using a mouthwash very regularly is that there are some mouthwashes which can actually strip away the oral microbiome or cause staining or problems themselves. With that being said, however, so whenever we have a patient, before we actually start treatment, we make sure that they have a pre-procedural rinse. And we usually use CPC, so citalopyrimidine. I can never pronounce it, but CPC I'm going to call it. And it's shown a lot of the research that's come out, especially in the UK. So in Sheffield University, they've just come out with a lot of research looking at different mouthwashes, whether alcohol, essential oils, what is it that could potentially kill the virus? And they are showing that pretty much all mouthwashes do have some antiviral activity. But like what Dr. Doneen was saying, it will stop the virus that is in your mouth at that moment in time, but it will not stop the replication of any viruses, which have already which are already intracellular. So I think it's a really great so for me, for example, I use mouthwash very regularly now. If I'm going for a run, for example, I'll have a bit of mouthwash when I come home, or, when I come home, a little bit of mouthwash just to kill, if there was any virus, just to kill any kind of transient virus that's just there. And I'm going to continue to do that. But if I was to have any kind of problems, or if there was a patient who had COVID-19, 100% nasal irrigation with saline would be my go-to choice. And I've already told a lot of friends of mine who have it, and they said that they were recovering so much quicker. And moving on from the mouthwash, toothpaste, making sure that you're brushing your teeth regularly. A lot of people, when they fall ill with any viral or bacterial infection, they kind of forget to brush their teeth, or they're too tired, or, that's the worst thing you can do. And there's a lot of research that was in Brazil, which was fascinating. And it was by chance that they found that basically patients who were being hospitalized, they were forgetting to brush their teeth. They were being hospitalized with COVID-19. And some patients were conscious and they were able to brush their teeth. A lot of them were unconscious, though, and that's the issue. And so there were a couple of patients, they said, we're not going to release anyone from ICU until they test negative on PCR 3 days in a row.
Great. So I was smiling when you were pronouncing cetylpyridinium chloride, so I just wanted to butcher it. And I was smiling because I was going to tell you what else I did, and I didn't want you guys to make fun of me. But I actually, a lot of mouthwashes now do have CPC in it, and that was part of my regimen. So my question is, and this is not a plug for Procter & Gamble. I actually don't get paid for any of this, but I did use Crest Pro Health mouthwash, which I did it in part because there was a study at Penn State School of Medicine, Dr. Myers there, that found it was 99.99% effective at killing a virus similar to COVID-19, and they used that. Now that was in a petri dish, so not in a mouth, but I extrapolated out and I said I'm going to hit this thing with everything I can, with the saline rinse and with all the using the Netipot to really get up in there, and I also used that. So question is, two things. One is getting a lot of questions for frequency. So Dr. Doneen, perhaps a comment of, so how often should one do this? And I don't think I went crazy. I just think I just went at it full guns. Can you do too much? So that would be the question.
Yeah, great question. So if someone has acquired COVID-19, then the recommendations is really to do this nasal irrigation and throat gargle every 2 hours, because we want to continually bathe those epithelial cells and get that innate immunity response going. On the day-to-day, just as Victoria said, I do it as she suggested, and that she does. I do it in the morning, I do it after my runs, I do it when I go to the grocery store and come back. I do it before and after work. You can do it really as frequently as you can tolerate. The concentration is not assaultive to the epithelial cells, so it really isn't problematic as far as injury goes. But and hypertension, I've been asked about that as well. Will this high-dose saline solution create a hypertension crisis? And the answer to that is no. It doesn't get systemically into the body, and it's not part of a food requirement of sodium.
Okay. So if you don't mind, what's the mix again? We've definitely hit a chord with the oral rinses. Yeah, so what would be the ratio?
A 2-to-1. So okay. 2 cups of distilled water to 1 tablespoon of salt. And it does not matter if it's iodized or non-iodized. There is recommendation that a non-iodized stings less, but they both work the same.
Great. And again, I wasn't crazy to do that. And also, gargle with whichever brand you like, but mine was Crest Pro Health. No problem sort of hitting it with that and adding in the hydrogen peroxide if need be, or PVP, no problem there.
Can I just say one thing, Dan? I am not suggesting that this treatment should replace any protocols that are within a dental office. That's not my wheelhouse. As Victoria said, using some pre-treatment rinse to mitigate the presence of the virus within the mouth before treatment is started. So I'm talking about it more on a general standpoint. I am not skilled. It's not my wheelhouse to suggest what protocols are utilized in dental offices.
Great. No, very much appreciated. And I will say, somebody asked, is it okay to use a Netipot? And I'm going to say, I sure hope so. I'm seeing her head nod because that's what I use.
You bet.
All right. Well, excellent. I certainly do appreciate that. I know a lot of the folks are listening, again, want to know what can they be doing right now so that if they do come in contact with it, that if at least they can look at themselves in the mirror and say, I did all I could to prepare my body for that. So really do appreciate that.
Let me just finish that topic real quick.
Please.
Decrease the severity within an individual by 2 to 3 days. And then, as Victoria said too, by stopping the shedding, it stopped the shedding and the spreading within households. So that's just something to remember as well. Okay.
And what I was hoping to do now, because I do want to be conscious of time. And by the way, at the end of the hour presentation, we certainly will have Q&A for another half an hour. So please don't feel that we will be stopping. But I do want to recognize that there's a good chunk that to get through here. I did want to go back to one thing, because it's come up a couple of times. If you don't mind, Dr. Doneen, I'm going to go back to statin. And just Sure. If you could chat about, I'm on a statin, and I guess I'm glad that I was on a statin. So why? Why does a statin, there we are. Why does a statin
let me go
have
back.
Therapeutic value?
Yeah, great. I'm glad you brought that up, because it does. If you look at the demographic of people that are of the highest risk, which I mentioned before, they're my people. They're the people who have vascular risk. And so when they looked at, upon entry on medications to the hospital with a positive COVID diagnosis and a severe case that needed to be hospitalized, they looked at mortality rate decrease based on just medicines we use to protect the arteries anyway. And the two that really shine makes a lot of sense are ACE inhibitors, because the ACE2 receptor is a big player in this process, and then statin therapy as well. Both significantly and independently dropped the mortality rate from COVID. Now, the reality is there's not enough data to suggest that if someone didn't need these medicines, that they should go on them. But if you happen to be on them, you're on them for a reason, and you are of a higher risk demographic, so it's time more than ever to stay on your treatments. Why do they work? work. ACEs have this beautiful anti-inflammatory effect to protect the endothelium. Remember, that's the very important lining of the artery to prevent plaque rupture and thrombus. And then from a statin standpoint, they do more than lower cholesterol. Matter of fact, I would say that's an oh, by the way, side effect. The value of statins is their anti-inflammatory benefit of allowing to sort of, I just call it a blunting of that aggressive response to the virus itself by affecting antigen presentation, cytokine production. All statins lower these. They also improve endothelial function, and they also affect tumor necrosis factor B, which is a pathway we want to block, because if we can block those pathways, we can prevent that cytokine storm. So more than ever, if you happen to be on a statin or an ACE, you're on it for a reason. And during this pandemic, it's really important that you stay on your medications, including your antiplatelets and so forth.
Okay. Appreciate that. Dr. Samson, wanted to talk to you about just the bacteria. Is this something where the bacteria is introduced during all of this? Is it there? Like, how is the connectivity between the virus and the bacteria?
Sorry, I'm back. By the way. I'm sorry for kind of leaving for a little bit.
Oh, no worries.
They switched off the internet because I'm still at work, but they closed the practice and they switched off my Wi-Fi. So I'm sorry, but I'm back now. So in terms of bacteria, there's two options. There is the option that the bacteria is already in your mouth, and the other option is that you inhale the bacteria or you eat it. And so if we're looking at the first option of the bacteria actually pre-existing, it's this idea that, we constantly have, we have an oral microbiome with 2 billion bacteria, 700 different species, and it's normal. We are meant to have an oral microbiome with lots of different bacteria. But the problem is that there are a lot of patients out there who have very high levels of maybe pathogenic bacteria, or, they might have active gum disease and they may not be aware of it, or they might have a lot of decay, and that will alter their oral microbiome. And generally, they may not have any symptoms. They may not even know about it. But the problem is that if you are to have a viral infection, then what we were talking about earlier, this idea of your body fighting this virus, then means that no one's taking care of that bacteria. So that bacteria, which is already there, starts to grow, it starts to develop, and then it can actually start to have symptoms and effects. So if we look at this diagram here, kind of the mechanisms of oral bacteria being introduced. So the first one is the idea of oral pathogens just being breathed into your lungs. Very simple, easy one. And then the second one is this idea of patients who have gum disease. The periodontal enzymes that are released from gum disease will actually modify the mucosal surfaces of the mouth. And it will kind of make the mucosa sticky, is how I like to call it, and very attractive to respiratory pathogens. So what this means is that actually a patient who has gum disease might be more likely to catch respiratory pathogens or viruses or bacteria because their mucosa is actually a little bit more sticky than the average patient. So that means that they're more likely to get COVID-19. Then the third one is this idea that the respiratory epithelium, so now we're talking about down into the lungs, and that can actually be altered by periodontal associated cytokines. So that again is cytokines which are released from gum disease, and they will promote infection from the respiratory pathogens. And again, it's because imagine the respiratory epithelium is sticky and it is attracting any respiratory pathogens, which will then mean that if you do have COVID-19 and it starts in the mouth, you're more likely to get it to travel down further. And so this is kind of the main idea behind a lot of respiratory diseases. And, you know, again, it's not just COVID-19, which has a potential link with the mouth, but it's a lot of, you know, pneumonia related kind of problems where it starts in the mouth. And we see it a lot in, I think I have a diagram. Where is the diagram? No. No, okay, I don't have the diagram. But what I was trying to kind of show you is that we've had these types of bacterial superinfections causing respiratory diseases long before COVID-19. And actually, pneumonia is the biggest killer of patients over the age of 70, especially in care homes. And a lot of research has been done into the connection between poor oral hygiene or poor denture cleaning and respiratory disease and pneumonia. And there's a huge connection between them. And what actually people are starting to see is that the bacteria, which is associated with gum disease and with decay as well, has been found in the lungs of patients who have died from pneumonia. And that again is that there's a huge interchange between the bacteria, which is in our mouth, and our lungs.
Thank you for that. One of the things that was popping through my mind during that, Dr. Doneen, is that a lot of what she was saying and Dr. Sampson was saying, like, this isn't new to COVID-19. This response isn't new to COVID-19. This is just being presented. This is just how our body reacts to things. And the one word that was popping into my head is inflammation. Mm-hmm. And if you don't mind, I'd like to turn you to what was my favorite slide of all the Dale Doneen day or 2 days I sat through. And how does this all come together? Could you help folks with a broad understanding
Sure.
of really how our bodies work and react?
Yeah, so I love that you brought up, and the word inflammation has come up several times, and the beauty of there's good and bad to everything. The beauty of COVID-19 is that we're rediscussing what has gone on throughout history, and that is health is defined basically as a lack of inflammation. Poor health, however we want to define it, is an inflammatory process. So in my world, I treat arteriology, which is the health and wellness of the arteries to prevent things like heart attack, stroke, dementia, macular degeneration, end-stage kidney disease, peripheral vascular disease. That's what we do to keep the artery. Those are the things we want to prevent by keeping the arteries non-inflamed. The reason that I've had the honor to meet so many people in the dental community, including Dr. Samson, is because we have believed all along that periodontal disease through high-risk periodontal pathogens and endodontic disease as an infection have equal play in the promotion of vascular inflammation as much, Dan, as everything else. So in the current model of cardiovascular disease, it's really too bad because heart attacks have remained the #1 cause of death in the world, basically in the US for sure, since the 1900s. Strokes are the leading cause of disability. Periodontal disease is the most common bacterial infection. So the coordination of the two definitely are there. But in standard medicine, 3 things are really dealt with if you might have cardiovascular risk: cholesterol, blood pressure, and nicotine exposure. But as you can see under this, what we call our root cause tree, there's lots of different causes of vascular inflammation, including things like airway and sleep, vitamin D deficiency, genetics, autoimmune diseases, insulin resistance, prediabetes, genetically inherited lipids like lipoprotein A. I could go on and on. But the reality is all of these entities or disease states or risk factors have a direct causal effect to create vascular inflammation, promoting the idea of plaque rupture thrombus, causing heart attacks or strokes or microvascular disease.
Thank you. Remarkable. So just a quick check-in. We'll be coming to the conclusion of time with the main presentation, and then we'll go to Q&A. I've certainly been reading the comments. I have a whole list of questions to get to you all. Before I do that, I would like to throw my first question to both of you individually, which is, as we've been talking about this subject, each of you could speak on this subject for multiple hours, right? What I want to make sure you get to is when we tried to say, hey, what's most important to this audience right now? What do people really need to know? We tried to distill it to that. Are there things that, before we go to the Q&A, that you really would like to make sure that, hey, before this our attendees drop off today. I want to make sure we get to X, or I want to tell them this or show them this. Is there anything before I start going to the questions that you'd like to start with, actually?
Why don't you start, Dr. Samson?
Thank you.
That's the most annoying question you'll get, I promise.
Yeah. Well, like you said, I mean, I could probably go on for hours about this, but one of the main things that I really want people to take home is this idea that there is a connection between specifically periodontal disease and systemic disease. And I don't think enough dental professionals potentially understand this, or definitely don't tell their patients about this. And I feel that now that I've started to tell my patients, look, you've got gum disease. This can increase your risk of cardiovascular disease, of potentially respiratory pathogens and infections. Patients will start to take responsibility of their gum disease and take care of themselves a little bit more. So that's number one. And number two is this idea that periodontopathic bacteria, so, you know, P. gingivalis, Prevotella, those are the main bacteria which cause gum disease. And they are also associated with systemic inflammation, and particularly the kind of word of the day that everyone loves at the moment is interleukin-6. And we know that interleukin-2, 6, and 10 are heightened in periodontal disease. And those are exactly the same cytokines which are heightened in a COVID-19 infection, and especially in patients who are having severe complications. So there's so much more research that needs to be done, but, you know, just telling your patients to improve their oral hygiene, to try and take responsibility of their periodontal disease and to try and control it, not only is good for themselves, for their systemic health, but also the idea that you could actually be helping them, if they are to get COVID-19, to reduce their risk of developing complications and bacterial superinfections and a cytokine storm.
Excellent. Thanks so much. Dr. Doneen?
Thank you for that. I just want to say we're treating the same disease, right? We're treating vascular inflammation. We're treating inflammation as a whole. And if we remember, it's the body's aggressive response to this virus that really creates the systemic result, which oftentimes can be deadly, as we know. As Dr. Samson so appropriately said, if we have the ability to control dangerous high-risk pathogens in the mouth, we have the ability to affect that overall systemic inflammation. When we published that paper in 2017 showing that these high-risk pathogens, which she just mentioned, AAPG, TFTD, FN, et cetera, those pathogens are not just associated, but actually causal of atherosclerotic disease progression. And I won't go into that now, but the point is, this is connected to the rest of the body. And if there's anyone on the line that's on the medical side, please realize that the oral pathogens are so important for systemic health and wellness. And I will scream from the rooftops that you cannot prevent cardiovascular disease without a good oral health program. So to the hygienists out there, the dentists out there, the dental assistants out there, the educators out there, keep fighting the fight, because now more than ever during this pandemic, we want to reduce that cytokine storm and that inflammatory response to COVID, and I would argue any virus.
That's great. Appreciate it.
And I think, can I just interject really quickly as well? I think what's beautiful about today's webinar is the fact that it's a medical professional and a dental professional who are sharing something that they're both passionate about, but from different angles. And one thing that we're really seeing with COVID-19 is that, first of all, the whole world is in it together. We're all experiencing the same thing. And for the first time in a very long time, research is being shared between all different types of, doctors, dentists, etc. I think there's something really beautiful about that. And I think the problem is that a lot of the time dentists think that they just treat here and that is it. And they don't think about how their treatment actually will impact the rest of the body, and vice versa. A lot of medical professionals don't understand that they can treat the body, they can do everything perfectly, but if the patient has an awful mouth, then that will directly impact their prognosis and their treatment. And I think the kind of discovery of new kind of markers, biomarkers, being able to understand, the levels of bacteria and all of that is going to be able to kind of translate what doctors know what dentists know, and it kind of meets in the middle to be able to say to, for example, if I was working with Dr. Doneen, if I was lucky enough to be in the same country, it would be amazing to be able to see a patient and say, look, these are her inflammatory markers. This is her, accelerated level of collagen breakdown, for example, her AMMP8 levels, and then say, can you treat the patient from a medical point of view? And I think that's the future for us.
Excellent. And I know from our perspective, we're seeing that 100%. We believe that the days of siloed clinicians, each with their different specialty, and we understand there's different schooling, but licensure and governance and all of it, and the data they get to see. And then all the way down from a patient perspective, I've got to remember which wallet do I need to bring to which clinician. And some of them, my dietitian or my mental health, well, they don't cover anything. And I've got to figure all that out and rationalize it. I almost feel like I'm ripping myself into pieces and stuffing them into these different silos. We think that that's all coming crashing together. And we think it's based on science and the best interest of patients, that we are all health systems of one. And we should expect our clinicians to all be able to collaborate around a shared data set to really be able to do what you're both talking about. And we don't think that's a dream. We actually think that that is quickly becoming a reality, which is very, very good.